Today we are going to discuss the disorders of iron and heme metabolism. These are typically our anemias that cause a microcytic type of anemia where the cells are smaller. All right, so a little anemia overview. Iron deficiency anemia is probably the most common type of anemia, and I'm sure you've heard of this one before. That one results from an inadequate store of iron, either from the diet or having some type of an inability to absorb the iron through the intestine. Anemia of chronic inflammation is another one. This one results from impaired mobilization of iron. So if you have let's say some severe type of arthritis or some type of inflammation going on somewhere in the body, that can make it very difficult to get to the iron where it needs to be. Then we have sideroblastic anemia, and this one results from the red blood cell defect which prevents the iron getting into the heme of the cell itself. And if you remember from basic hematology, the center of that heme molecule is a big old piece of iron, right? So if we can't get that into the heme, obviously we're going to be anemic as well. So first we'll start with the iron deficiency anemia. So this one, like I said, develops when an intake of iron is inadequate, when the need for iron expands, such as pregnancy, something like that, or when there's a chronic loss of hemoglobin from the body. Any type of blood loss could be from a number of different types. Sometimes people have a slower blood loss over time, which could also cause an iron deficiency anemia. So when we look at how this occurs, it usually develops slowly and it progresses through these three stages. But it's first important to understand that there's three compartments that store iron. You have to memorize this. You will be tested on this. The storage form of iron in the body is known as ferritin. It is transported by transferrin. That one's usually pretty easy to remember because trans sounds like transport. So you transport iron with transferrin. The functional forms are found in hemoglobin and myoglobin. So these are the different stages of iron deficiency anemia. Think of somebody who maybe has just gotten pregnant and their iron stores, they're not going to have the iron stores they need because they're going to need more, right? So the first stage is the iron becomes depleted. Maybe they've got some severe nausea and vomiting, they're not eating like they should, babies requiring more iron, all of those things come into play. The first thing that starts to decrease in the first stage is our ferritin starts to go down, the storage iron. In stage 2, our transport iron starts to be depleted. Our hemoglobin is still normal in this stage, but our serum iron starts to decrease, and our ferritin starts to decrease. You'll notice at this point, the total iron binding capacity starts to increase because we have the capacity to bind more iron, but it's not there to bind. Okay, so make sure that you have that straight. This is the only type of anemia where we see an increased total iron binding capacity. Once you get to stage 3, this is where there's a total depletion of functional iron. This is where you have actual iron deficiency anemia. This is where the hemoglobin levels go down, the serum iron goes down, your iron binding capacity is even higher than it was before, and the ferritin levels are still low. So with iron deficiency anemia, when you become diagnosed, everything is decreased except the total iron binding capacity. You see this one in a lot of case studies too. All right, so what is the epidemiology of this? Certain groups of people are more prone to having iron deficiency anemia. For example, menstruating women, adolescent girls, pregnant and nursing women, which is what I just mentioned, and growing children. So of course, as there's an increased need for iron, if the iron isn't being provided, they're going to end up being iron deficient. When we look at the laboratory diagnosis of iron deficiency anemia, we do some tests to screen. So some of the screening that is done, we do a CBC. The complete blood count shows the microcytosis and hypochromia as seen in iron deficiency anemia. Other types of anemia would look different. Their hemoglobin would be decreased along with their RBC count, their hematocrit, and they may have an increased RDW. The RDW, as we talked about last week, is where you have a variety of size of the red blood cells, right? So you may have a lot of small ones and a lot of big ones. The red cell distribution width being larger means there's a lot of different sizes present. We'll also see poikilocytosis if iron deficiency is severe enough. We may see target cells and elliptocytes, for example. All right, so a diagnosis is usually not made until we see those things on the CBC. We do iron studies, which would be a serum iron, the total iron binding capacity, the transferrin saturation, and a ferritin. Those things would help clue them into the fact that there's iron deficiency. From this point, they would provide the patient with extra iron and see if this kind of plays out. You want to start with the tests that are least invasive and then move your way to more invasive tests if in fact the iron, replenishment doesn't work. So in most cases when they treat them, like I said, they give them iron, but if they have another underlying cause such as parasites or an ulcer, they would have to treat the parasites or the ulcer, but in most cases they try the dietary supplement because it's a really easy fix. Here's what microcytic hypochromic anemia might look like in somebody with iron deficiency anemia. You can see here that most of the cells are almost see-through. They have a large area of central pallor. We talked about central pallor last week too, and that's that large area they look almost see-through. A normal red blood cell would look more like this one over here. So you can see that the majority of them are quite sick-looking and quite pale. The next type of anemia is anemia of chronic inflammation. This one's most common amongst hospitalized patients. They're usually inflamed because of another disease process. And this one used to be called the anemia of chronic disease. The etiology of this one is where the iron absorption is decreased during the inflammation, and it makes that iron unavailable to those poor developing RBCs. So if they're not able to get it to where the iron to where it needs to go, obviously it's going to affect that RBC maturation. So here are some other tests that are involved. We may look at some acute phase reactants. Okay, so hepcidin, which regulates the body's iron levels by reducing the amount of iron absorbed. So that may come into play. Lactoferrin, which is the iron binding protein in the granules of those neutrophils. And ferritin, which is the increased levels of plasma that also bind iron. So those are some other things that we would look at when we're considering somebody may have anemia of chronic inflammation. Iron is present in the bone marrow macrophages, but its release to the developing erythrocytes could be slowed. In this case, the iron stains would show iron in those macrophages, but not in the erythroblasts. So if the macrophages are eating up all the extra iron, that can be a problem as well. And it's something that we would see with chronic inflammation. So looking at the laboratory diagnosis of this one we would do a CBC with a peripheral smear. The hemoglobin would be low. We would probably not have reticulocytosis, which we may or may not see with the iron deficiency anemia. This one would be normocytic normochromic, where we saw iron deficiency was hypochromic microcytic. We would do iron studies. This one would have decreased serum iron and a decreased TIBC. Remember, we had the increased TIBC with the other one. We would do a Prussian blue stain of the bone marrow, and that would confirm abundant stores of iron in the macrophages, but not in the RBC precursors. We want the iron to be in the RBCs where it belongs, not in the macrophages. There's also some more specialized tests. We can look at serum transferrin receptors. So these are receptors that are sloughed from the cells into the plasma. It's increased in iron deficiency anemia, but this one would be normal in anemia of chronic inflammation. With these patients, we usually treat with a therapeutic erythropoietin, which normally comes from the kidneys, to try and boost the production of those red cells. And they also give iron because the stored body iron is actually unavailable, so they have to provide it more often. And the third one we'll talk about today is the sideroblastic anemia. Sideroblastic anemia interferes with the production of adequate amounts of heme. So the iron is totally abundant in the marrow. It's just not able to go where it belongs. So the lab diagnosis of this one, we see a microcytic hypochromic anemia under the microscope. We would do a Prussian blue stain of the bone marrow, and that would show iron deposits in the normoblasts in the mitochondria, where the chronic inflammation, we would find it in the macrophages. So the location of the iron in the mitochondria shows that the iron is waiting to be incorporated into the heme, and we see ringed sideroblasts. So this is the hallmark of sideroblastic anemia, seeing those ringed sideroblasts. And it's always nice when the disease sounds like something that's involved. Sideroblastic anemia, we see ringed sideroblasts. This one's a little bit different with treatment. We don't give these people a bunch of iron. We give them pyridoxine, and that helps stimulate the iron synthesis. Here's a picture of some ringed sideroblasts. You can see the iron around the cells. And we have a couple different types. One of the things that can cause sideroblastic anemia, the first one, lead poisoning. So lead interferes with the porphyrin synthesis at several steps. You don't have to memorize these steps, but I'll read them to you. We have a conversion of the aminolevulinic acid to porphobilinogen that results in an accumulation of the aminolevulinic acid. And we have incorporation of heme into the protoporphyrin 9 ring by ferrochelatase, resulting in an accumulation of iron and protoporphyrin. So with this, they typically end up anemic. They have mental effects from it. And if you've ever heard of people getting lead poisoning, it's usually young children. Back before the 70s, paint was made out of lead, and children would either chew on the paint on the old cribs, or sometimes the window sills would have chips of paint, or even chips of paint outside. Those are some common ways that we would see lead enter, into a child's system. But nowadays, newer houses, newer paint, we usually don't have lead-based paint anymore, so we don't see it to be too much of a problem, but it can cause impaired mental development. They can also end up with a peripheral neuropathy in their hands and things like that. They can also have abdominal cramping, vomiting, and seizures. With a lab diagnosis of lead poisoning, we see normocytic, normochromic, but a chronic exposure can become microcytic hypochromic. These people would have an elevated reticulocyte count. They would have a basophilic stippling, and as you can see here, it looks like little spots. And basophilic stippling is actually undegraded ribosomes aggregating. In the treatment, they give salts of ethylene diamine tetraacetic acid. And if you know anything about phlebotomy, that is EDTA, the same EDTA that's in those tubes that we draw. That will chelate up the lead in the body, so it's excreted in the urine, and we get rid of it. The next type is a porphyria. A porphyria is considered a sideroblastic anemia. And with this one, we see impaired production of heme, and it can be acquired or hereditary. Lead poisoning can be an example of an acquired porphyria, and we can see deficiencies of enzymes in the heme synthesis pathway. So as we've learned in the past about the synthesis of heme and the different steps, there may be an enzyme from the conversion of one to the other that can cause a problem. Another issue we can see with iron is actually iron overload. So this is from an excess accumulation of iron that results from acquired or hereditary conditions. So regardless of the source of iron, the body stores the excess iron in the form of hemosiderin within the cells. Eventually, the system becomes overloaded and the parenchymal cells are damaged in the liver, heart, and pancreas. With hemochromatosis, this develops as a result of the mutations affecting the proteins in the iron metabolism, and they end up with way too much. So with these people, all the cells except the mature RBCs require iron and can acquire it. Most cells have the potential for iron damage. The skin kind of turns a golden color. We can end up with cirrhosis and liver cancer. The pancreas, you can develop diabetes. With the heart, it can lead to congestive heart failure. This one is more common in men. So they usually have 20 to 30 grams of iron, which is 10 times normal. So hemochromatosis, iron overload. In the lab, with a screening, an increased transferrin saturation of greater than 60% could be common. We can have a diagnosis of organ damage. We have abnormal liver function tests. We monitor the treatment, so ferritin provides an assessment of the degree of iron overload, so we can do ferritin levels. And we also monitor the hemoglobin and hematocrit. With this one, they end up with too much blood. So a therapeutic phlebotomy is used to try and pull some of those cells out to get rid of some of that excess iron. They can also try iron chelating drugs as well. And that concludes our first section of anemias.